Welcome to Bookfulness. This is episode 22 of our series, Clinically Oriented Anatomy. In the last episode, we explored the complex geography of the retroperitoneal organs. Today, we conclude our comprehensive study of the abdomen by examining its roof, the diaphragm, and the fundamental scaffolding that forms its deep posterior boundary.
That's right. Our mission for this deep dive is to synthesize the essential anatomy and the critical clinical points spanning original pages 899 through 927. We're moving from the chief muscle of breathing down through the deep core structures that stabilize the trunk, charting the course of the major vessels and nerves, the crucial internal highways, that either traverse this region or originate from it. You'll find this region is less about complex organs and more about vital, muscular, and, well, vascular architecture.
Okay, let's unpack the ceiling of the abdomen, the diaphragm. Our sources define it beautifully as this impressive double-domed sheet, which simultaneously serves as the mobile roof of the abdominal cavity and the floor of the thoracic cavity. It is, without question, the chief muscle of inspiration, driving the mechanical process of breathing.
It is the primary engine, absolutely. When the diaphragm contracts, its domes descend, they flatten out, which dramatically increases the vertical volume of the thoracic cavity. This creates a negative pressure, drawing air into the lungs. But simply calling it a respiratory muscle misses its critical dual function.
That dual function is key. You mentioned circulation, so the mechanical action creates a kind of circulatory synergy. How significant is that pressure difference in reality?
Oh, highly significant. When the diaphragm descends, it simultaneously increases the pressure inside the abdominal cavity and decreases the pressure inside the thoracic cavity. This differential acts like a reciprocating pump, really. The surge in intra-abdominal pressure effectively squeezes blood from the abdominal veins superiorly.
Right.
At the same time, the drop in intrathoracic pressure sucks venous blood into the chest, specifically helping the inferior vena cava, the IVC, return blood to the heart. It's a beautifully engineered, sort of low-energy system for enhancing venous return.
Okay, speaking of structure, that functionality relies entirely on its complex attachments. How do we break down the diaphragm's origins? Where does it actually anchor?
Well, we distinguish three main peripheral muscular parts, and they all converge centrally onto the central tendon. First, the small sternal part, which consists of two slips attaching to the posterior aspect of the xiphoid process. It's the smallest part, actually, and sometimes it's even absent.
Interesting. Okay, then you have the most expansive part, the costal part. This sounds like the main workhorse.
It really is. This forms the sweeping arches of the diaphragm, the domes attaching via wide slips to the internal surfaces of the inferior 6 costal cartilages and the adjoining ribs. These slips form the bulk of the contracting muscle tissue. And finally, the essential lumbar part. This arises from the lumbar vertebrae via two musculotendinous bundles called the crura. Singular is crura.
Crura, right.
The right crus is typically longer and thicker, arising from the bodies of L1 through L3 vertebrae, while the left crus usually arises only from L1 and L2. All these muscular origins merge into the large, flat, aponeurotic structure at the center. That's the central tendon.
That central tendon is critical because it's not just a passive meeting point, is it? It's the site of one of the diaphragm's major gateways. Let's talk about those three principal apertures, because understanding not just what passes through them, but how it passes through seems fundamental for clinicians.
Precisely. Table 5.12 and Figure 5.95 lay out the hierarchy of these gateways really well. They're defined by their position and the structures they pass through, which dictates their functional response during contraction. It's all about location, location, location here.
Okay, so first, the highest and most anterior opening is the caval opening, or vena cavale foramen. This one is uniquely situated where?
It's uniquely situated within the central tendon itself, typically around the level of the T8 vertebra.
In the tendon, not the muscle.
Exactly. Its location in the dense, fibrous central tendon is functionally crucial. The central tendon doesn't constrict significantly when the diaphragm contracts. In fact, the IVC is sort of held open by its attachments to the tendon margin. The combined effect of the vessel being tethered open and the sharp drop in intrathoracic pressure during inspiration maximizes blood flow into the heart, directly reinforcing that circulatory synergy we talked about.
Makes sense. And what exactly goes through there besides the IVC?
It transmits the inferior vena cava and also small branches of the right phrenic nerve, plus some lymphatics.
Okay. Next, we move slightly inferiorly and medially to the esophageal hiatus. This is an oval opening, often located around the T10 vertebra. And critically, its location is different, isn't it?
Very different. It is located entirely within the muscle tissue of the right crus of the diaphragm, not the tendon.
Ah, okay, so passing through muscle has different implications.
It does. Because the esophagus passes through muscle, the fibers of the right crus decussate. They cross over inferior to the hiatus, forming a physiological muscular sphincter around the esophagus. When the diaphragm contracts, this sphincter constricts the esophagus. This is a primary component of the body's anti-reflux mechanism, helping prevent gastric contents from backing up into the chest.
That's fascinating. So the diaphragm's contraction helps keep stomach acid down. Since the aortic hiatus doesn't constrict during inspiration, but the esophageal hiatus does, what implications does that muscular constriction have for the other delicate structures that pass through there alongside the esophagus?
Well, it means they're exposed to dynamic compression with every breath. Along with the esophagus, the hiatus transmits the anterior and posterior vagal trunks. These are major branches of the vagus nerve.
Right, the vagus nerve.
Also, the esophageal branches of the left gastric vessels and lymphatic vessels pass through. These structures must tolerate the rhythmic squeezing that occurs, though the vagal trunks are relatively resilient, thankfully.
Okay. Finally, the most inferior and posterior gateway is the aortic hiatus, located at the level of the T12 vertebra.
And this is where we see the key functional exception, the big difference. The aorta does not pierce the diaphragm muscle or tendon. It passes posterior to the diaphragm. It's situated between the two crura and runs posterior to the median arcuate ligament, which is basically a fibrous arch connecting the medial borders of the two crura.
That functional distinction is massive.
Oh, wow.
What's the practical implication of the aorta bypassing the muscle entirely?
It ensures homeostatic blood flow. It's absolutely critical. Since the diaphragm's contraction does not constrict the aorta, blood flow and systemic pressure remain constant regardless of respiratory cycle intensity. Imagine if the aorta were squeezed every time you took a deep breath, your blood pressure would fluctuate wildly. That would be problematic.
Definitely.
The aortic hiatus also transmits the thoracic duct, which is the main lymphatic vessel, and often the zygos and hemiazygos veins as well.
Before we move on from the diaphragm's openings, we should probably highlight the minor ones too. They're often sites of, well, potential vulnerability, right?
Yes, absolutely. There are smaller, often overlooked gaps that are clinically relevant. The sternocostal triangle, sometimes called the foramen of Morgagni, is a small non-muscular space between the sternal and costal parts, right up front.
Morgagni. Okay.
It's small but important. It transmits lymphatic vessels from the liver's diaphragmatic surface and the superior epigastric vessels, which are continuations of the internal thoracic vessels. And the crura themselves have small apertures transmitting the three sets of splanchnic nerves, the greater, lesser, and sometimes the least splanchnic nerves, as they descend from the thorax into the abdomen to supply the abdominal viscera with sympathetic innervation.
Got it. Let's talk about the nerve supply controlling all this movement and what happens when it fails. The diaphragm is served exclusively by the phrenic nerves, originating from the anterior rami of C3, C4, and C5 segments of the spinal cord, the classic mnemonic.
C3, 4, and 5 keep the diaphragm alive. It's essential. Those phrenic nerves provide the motor supply to the entire diaphragm, each nerve supplying its own hemidiaphragm. They also provide sensory supply, but mostly to the central part of the diaphragmatic peritoneum below and the pleura above. The periphery gets sensory innervation from the lower intercostal nerves.
Which makes the diaphragm uniquely vulnerable to neck injuries or thoracic issues affecting that C3, C5 spinal cord area, or the phrenic nerve's path through the neck and thorax.
Right.
And if those nerves are injured, we see the phenomenon of paralysis of the diaphragm and that counterintuitive paradoxical movement. Explain that for us again.
Okay, so if the phrenic nerve on one side, let's say the left, is damaged, that hemidiaphragm becomes paralyzed and flaccid. It loses its tone. Now, when the healthy hemidiaphragm contracts during inspiration, it pushes down on the abdominal contents, drastically increasing intra-abdominal pressure. This increased pressure pushes the paralyzed flaccid dome upward into the chest cavity, so it ascends when it should be descending. That's the paradoxical movement.
It's being passively pushed up by the pressure differential created by the healthy side's contraction, not actively contracting itself.
Exactly. And conversely, during expiration, as the healthy side relaxes and abdominal pressure drops, the paralyzed dome passively descends, following the elastic recoil of the lungs. Radiographically, like watching under fluoroscopy, this paradoxical movement is a clear diagnostic finding for phrenic nerve injury.
Moving from functional failure to structural failure, our sources detailed diaphragmatic rupture. They point out a massive statistical disparity. Something like 95% of traumatic ruptures occur on the left side. Why such a strong left-sided bias?
It's purely anatomical protection on the right. The substantial mass of the liver is intimately associated with the right dome of the diaphragm. This large solid organ acts as the physical buffer, absorbing traumatic forces and providing structural support that the left side simply lacks. The left dome sits relatively unprotected above the stomach and spleen, which are much softer and more mobile.
Makes sense. And these ruptures don't just happen anywhere randomly on the diaphragm, do they? They often target existing points of weakness.
That's right. Beyond the trauma itself, the vulnerability is often focused on the lumbocostal triangle, sometimes called the triangle of Bachdolek. This is a small, often non-muscular or thinly muscular area located posteriorly between the costal part attaching to the ribs and the lumbar part attaching via the crus.
Bachdolek, okay, so it's naturally weaker.
Yes, it's developmentally a potential weak spot because it's one of the last parts of the diaphragm to fuse. It's frequently a site for both traumatic rupture and, maybe more importantly, for congenital diaphragmatic hernias, where abdominal viscera herniates into the chest cavity during development. Understanding that small, potentially non-muscular gap is critical to diagnosing these congenital diaphragmatic hernias, which can be life-threatening if they compromise lung development.
Wow, okay, that really covers the roof of the abdomen. With the critical muscular partition and its major gateways charted, we now turn our attention downwards to the true internal scaffolding, the great vessels and deep core muscles, which run in immediate, intimate contact with the posterior abdominal wall. This section starts around original page 905.
Exactly. The posterior abdominal wall is the deep boundary of the abdominal cavity. It's not a solid, uniform surface, but a dynamic boundary formed by several key elements. You have the rigid structure of the lumbar vertebral column providing central support, then the major deep muscles, psoas major, iliacus, and quadratus lumborum. Covering these are specialized sheaths of fascia. And of course, coursing along this wall are the great vessels aorta and IVC and the major nerves of the lumbar plexus.
Let's start with the deep fascia covering this complex area. It's generally called the endo-abdominal fascia, but it develops specific thickenings tailored to the massive muscles it covers.
Indeed. We must differentiate between the major fascial components here, as they have significant clinical implications. First, the psoas fascia. This is a thick, membranous sheath that completely surrounds the psoas major muscle, attaching medially to the lumbar vertebrae and laterally blending with the fascia of the quadratus lumborum.
And you mentioned clinical significance.
Immense significance. This fascial sheath acts like a conduit. It guides the path of infection or pus, particularly from tuberculosis, affecting the lumbar vertebrae, what used to be called Pott's disease. We'll come back to the psoas abscess.
Okay, good point. Then there is the immensely important, though sometimes conceptually tricky, thoracolumbar fascia. This is much more than just a simple wrapping, isn't it?
Oh, absolutely. It's a complex, multi-layered fascial system. It's crucial for stabilizing the lumbar spine and transferring forces between the upper body, trunk muscles, and the pelvis. In this posterior abdominal region, it has three distinct layers that enclose the deep back muscles and the quadratus lumborum. The anterior layer covers the anterior surface of the quadratus lumborum and is continuous laterally with the transversus abdominis of ponderosus. The middle layer is posterior to the quadratus lumborum, and the posterior layer covers the deep back muscles like the erector spinae. This entire encapsulation system provides leverage for the deep core muscles and is crucial for maintaining posture and resisting rotational forces on the trunk.
That's a complex structure. Okay. Moving to the key muscles embedded within this fascia, we first examine the iliopsoas, which is really the functional combination of the psoas major and the iliacus muscles. They have different origins, but share an insertion and function, right?
That's correct. Topographically, the psoas major originates from the transverse processes, vertebral bodies, and intervertebral discs of T12 through L5. It runs down along the pelvic brim. The iliacus is this large, fan-shaped muscle that fills the iliac fossa inside the pelvic bone. Their tendons merge together, pass deep to the inguinal ligament, and insert onto the lesser trochanter of the femur. Their combined function makes them the most powerful flexors of the hip joint.
But you hinted earlier that for clinical diagnosis in this region, their location is more critical than their action.
Yes, their intimate anatomical relationship to the retroperitoneal organs is far more critical in this context. The psoas major lies immediately posterior or adjacent to several critical structures: the kidneys, the ureters, the cecum, the appendix, the sigmoid colon, pancreas, and lumbar lymph nodes.
And this a direct relationship leads us straight to a classic essential physical examination tool, the psoas sign. How does that work again?
So if any of those adjacent structures become inflamed, the classic example is acute appendicitis. But it could also be a kidney infection or inflammation around the ureter movement of the psoas muscle will cause pain because it rubs against or stretches the inflamed tissue.
Okay, so how do you specifically elicit this pain in the psoas test?
The standard maneuver is to have the patient lie on their left side, the unaffected side. The clinician then slowly extends the patient's right thigh backwards at the hip joint. This extension stretches the iliopsoas muscle. If this maneuver causes pain in the right lower quadrant or flank, that's a positive psoas sign. It strongly suggests that there's an inflammatory process, very likely involving the appendix or perhaps a retroperitoneal infection or even disease of the lumbar vertebral joints irritating the muscle. It's a really valuable, non-invasive clue pointing towards deep abdominal or retroperitoneal pathology.
A simple test with potentially significant implications. We shouldn't neglect the third major muscle here, the quadratus lumborum. It seems to play a quieter but essential role in stabilization.
It absolutely does. It's the deep stabilizer of the posterior wall, situated lateral to the psoas major and encased between the anterior and middle layers of the thoracolumbar fascia. It originates from the iliac crest and the iliolumbar ligament and attaches superiorly to the transverse processes of the upper lumbar vertebrae and, importantly, the medial half of the inferior border of the 12th rib. Its primary actions are lateral flexion, side bending, of the vertebral column, and crucially, it fixes or depresses the 12th rib during forced inspiration, providing a stable anchor for the diaphragm's contraction. Its innervation comes directly from the anterior rami of T12 through L4 spinal nerves.
Okay, deep muscles covered. Now let's navigate the nerve network that weaves through this muscular mass. A major takeaway from the text is the formation of the lumbar plexus. Where does this happen?
The lumbar plexus is formed by the anterior rami of spinal nerves, L1, L2, L3, and the upper part of L4. And its distinguishing feature, anatomically, is that it forms within the substance of the psoas major muscle itself. It's bedded right in there.
Inside the muscle. That's unusual.
It is. The nerves then emerge from the plexus, either medially, like the obturator nerve, laterally, like the femoral nerve, ilioinguinal, iliohypogastric, lateral, femoral cutaneous, or sometimes piercing right through the psoas muscle's anterior surface, like the genitofemoral nerve.
Okay, focusing on the nerves supplying the abdominal wall itself, which ones emerging from or running near this plexus are vital for the anterolateral abdominal wall innervation?
The key somatic nerves for the lower abdominal wall originate from this key 12L1 region, running between the internal oblique and transversus abdominis muscles. We have the subcostal nerve, which is the anterior ramus of T12, coursing along the inferior border of the 12th rib before penetrating the abdominal wall muscles. Then there are the crucial branches of L1, the iliohypogastric and ilioinguinal nerves. These descend across the quadratus lumborum, pierce the transversus abdominis near the acis, and run forward.
And why are these two, the iliohypogastric and ilioinguinal, so important clinically?
They are crucial because they supply sensation to the skin over the hypogastric region, pubic area, and the inguinal region, groin, including the scrotum or labia majora. They also provide motor function to the lower parts of the transversus abdominis and internal oblique muscles. Understanding their precise paths is absolutely critical for surgeons operating in the lower abdomen or inguinal region.
Why specifically for surgeons?
Because when making incisions, for instance during an appendectomy using a muscle-splitting incision, or particularly during inguinal hernia repair, surgeons must be acutely aware of their course to avoid injuring them. Injury to these nerves, even if minor, can lead to denervation and subsequent weakness or paralysis of the lower portions of the abdominal musculature. The consequence can be a weakened abdominal wall in that area, which significantly predisposes the patient to developing a direct inguinal hernia later in life. It's a direct link between detailed nerve anatomy and long-term surgical outcomes.
That makes perfect sense. We also find the autonomic component running along the posterior wall here, the lumbar sympathetic trunks. Where do they sit?
These trunks are the continuation of the thoracic sympathetic trunks. They descend on the anterolateral aspects of the lumbar vertebral bodies, just medial to the origin of the psoas major muscle. Each trunk typically consists of 4 interconnected lumbar ganglia. They contribute postganglionic sympathetic fibers to the lumbar spinal nerves for blood vessels, sweat glands, and also send visceral branches, lumbar splanchnic nerves, to join the aortic and hypogastric plexuses, which supply the abdominal and pelvic organs. They're a key part of the body's fight-or-flight regulatory system in the abdomen and pelvis.
Okay, so we've built the muscular scaffolding and traced the nerve supply. Let's shift our focus now to the true internal plumbing, the major vascular highways of the posterior abdominal wall. This section starts around original page 911. We're charting the course of the abdominal aorta and the mighty inferior vena cava IVC.
Right. The abdominal aorta is the continuation of the thoracic aorta. It begins as it passes through the aortic hiatus of the diaphragm at the T12 vertebral level. It descends on the anterior aspects of the T12 through L4 vertebrae. Crucially, as you look at the patient, it sits immediately to the left of the midline. This left-sided position is the first key anatomical difference compared to its venous counterpart, the IVC.
And its termination point is a key anatomical landmark, used often in imaging and surgery.
That's right. The aorta bifurcates, it splits into the right and left common iliac arteries. This bifurcation typically occurs at the level of the L4 vertebra. Clinically, this level can often be estimated externally by the supracristal plane, which is an imaginary transverse line connecting the highest points of the iliac crests on both sides. This landmark provides a reasonably reliable external reference for this major internal vascular division.
Useful. And the aorta's branches are numerous. The text categorizes them strategically by function or target, doesn't it?
It does, and it's a helpful way to think about them. We can divide the branches into 3 functional groups based on where they arise and what they supply. First, the unpaired visceral branches arise from the anterior aspect of the aorta. These are the celiac trunk at T12L1, the superior mesenteric artery, SMA, at L1, and the inferior mesenteric artery, IMA, at L3. They supply the gastrointestinal tract, the gut.
Okay, anterior means gut supply.
Then the paired visceral branches arise laterally. These supply paired organs. Examples include the middle suprarenal arteries, the large renal arteries at L1, L2, and the gonadal arteries, testicular or ovarian, arising around L2.
Lateral means paired organs.
And finally, the paired parietal branches arise posterolaterally. These supply the body wall itself, the diaphragm, and the posterior abdominal wall muscles. Examples are the inferior phrenic arteries, supplying the diaphragm, and the 4 pairs of lumbar arteries that run into the posterior abdominal wall musculature.
Posterolateral for the body wall. That's a clear system. There is also that small midline vessel mentioned that often serves as a surgical compass.
Ah, yes, the median sacral artery. This is usually a small, unpaired vessel that typically arises from the posterior aspect of the aorta, right near the bifurcation, or sometimes from one of the common iliacs. It descends in the midline anterior to the lower lumbar vertebrae, L4, L5, and the sacrum. For surgeons, particularly those using laparoscopy or performing pelvic surgery, this artery serves as an invaluable, relatively constant landmark for confirming the exact midline. It helps orient procedures deep in the pelvis.
Good to know. Now let's consider the venous giant running alongside the aorta, the inferior vena cava, IVC, which occupies the other half, well, the right half of the posterior wall.
The IVC is the largest vein in the body. It's significantly larger in diameter than the aorta because venous pressure is much lower. It runs to the right of the midline, parallel to the aorta. It forms by the junction of the 2 common iliac veins, typically at the level of the L5 vertebra, so slightly lower than the aortic bifurcation. As it ascends, it passes anterior to the vertebral column, the right psoas muscle, and the right renal artery. It runs posterior to structures like the duodenum, the head of the pancreas, the portal vein, and then enters a groove on the posterior surface of the liver before piercing the central tendon of the diaphragm at the cavale opening, around the T8 level.
Its tributaries generally mirror the paired aortic branches, but you mentioned earlier there's a vital anatomical asymmetry, particularly concerning the left renal vein. Can you elaborate on that?
Yes, this is a really high-yield anatomical detail with clinical consequences. The left renal vein is notably longer than the right renal vein. This is because the IVC is on the right side of the body. So the left renal vein has to cross the midline to reach the IVC. As it does so, it passes anterior to the abdominal aorta, just inferior to the origin of the superior mesenteric artery, SMA.
Ah, so it's squeezed between the aorta and the SMA.
Potentially, yes. That anatomical relationship creates a pinch point. Furthermore, the left renal vein typically receives the left suprarenal vein and the left gonadal vein, testicular or ovarian, before it drains into the IVC. These veins drain directly into the left renal vein first. In contrast, the shorter right renal vein drains straight into the IVC, and the right suprarenal and right gonadal veins usually drain directly into the IVC itself, not into the right renal vein.
That anterior course of the left renal vein crossing the aorta definitely hints at potential issues, often seen on imaging, like you said.
Absolutely. That specific anatomical choke point where the left renal vein passes between the aorta posteriorly and the SMA anteriorly is the classic site for potential compression or entrapment. This condition is sometimes called the nutcracker phenomenon or nutcracker syndrome. If the angle between the aorta and SMA is too acute, it can compress the left renal vein, leading to upstream venous hypertension in the left kidney, left gonad, and left adrenal gland. It highlights the tight, sometimes unforgiving geography of the retroperitoneal space.
Fascinating. The tight relationship between these great vessels and the deep musculature of the posterior wall also leads us to a really interesting concept discussed in the text: the body's innate collateral routes for venous return. What happens if the IVC gets blocked?
Right, if the mighty IVC becomes compromised, maybe by a large tumor growing around it, a deep vein thrombosis extending up, external compression, or even surgical ligation in some cases, the body needs alternate pathways for systemic venous blood from the lower limbs and abdomen to return to the heart. This is where the ascending lumbar veins and the azygos adios venous systems step in as, well, emergency bypass routes.
Okay, explain how that collateral bypass actually works. How does the blood find its way back?
The ascending lumbar veins are paired vessels that run vertically along the posterior abdominal wall, typically posterior to the psoas major muscle, alongside the lumbar vertebral bodies. Inferiorly, they connect with the common iliac veins, the iliolumbar veins, and the lateral sacral veins, effectively linking the venous drainage territory of the lower IVC. Superiorly, they communicate with subcostal veins and then pass through or behind the diaphragm, often through or near the aortic hiatus or through the crura, to become the azygos vein on the right side and the hemizygos and accessory hemizygos veins on the left side within the thorax.
I see. So the ascending lumbar veins act as a bridge.
Exactly. They form a continuous venous channel connecting the territory normally drained by the IVC below the blockage to the azygos system in the thorax. The IGO system then arches over the root of the right lung and drains directly into the superior vena cava, SVC.
So if the IVC is blocked, say, below the level of the renal veins, blood from the legs and pelvis can shunt up through the ascending lumbar veins into the azygos system, travel up through the thorax, and drain into the SVC, effectively bypassing the blocked abdominal IVC.
Precisely. It's an elegant, resilient system of venous redundancy. There are other collateral routes, too, like the epigastric veins on the anterior abdominal wall, connecting femoral drainage to axillary drainage. But the ascending lumbar to zygos pathway is the major deep collateral route for IVC obstruction. It really shows how the body often engineers a bypass, utilizing collateral circulation to ensure systemic venous flow is maintained even when the main highways fail.
That's incredible redundancy. Let's delve into a few more clinically oriented insights that specifically connect the diaphragm and the posterior wall structures we've discussed, perhaps moving beyond vascular emergencies now. We are looking at page 916 and onwards here.
Okay. Starting back with the diaphragm, we noted that while blunt trauma is the usual cause of acquired diaphragmatic rupture, inherent structural weaknesses are always present and clinically important.
Oh.
We discussed the lumbocostal triangle, a Bockelek, that small, potentially non-muscular area posteriorly between the costal and lumbar parts.
Right. What specifically is the concern with the lumbocostal triangle beyond just acute trauma? You mentioned congenital issues.
Yes, it is the most common site for congenital diaphragmatic hernias, CDH, specifically the Bockelek type hernia. Because that triangle represents a potential non-muscular defect resulting from incomplete fusion during embryonic development if it fails to close properly, abdominal contents like loops of intestine, the stomach, spleen, even part of the liver can herniate directly up into the pleural cavity, the chest cavity.
And that happens before birth.
Often, yes. This herniation occurs in utero and can severely compress the developing lung on that side, leading to pulmonary hypoplasia under development, which is often the main cause of mortality in severe CDH. And again, the presence of a large liver mass on the right side provides some protection, which is why these severe congenital defects are vastly more common, around 85–90% on the left side. It's an immediate life-threatening consequence originating from a small, localized anatomical weakness in the diaphragm.
A major developmental issue stemming from a small gap. Okay, moving down to the posterior wall muscles, let's revisit the psoas abscess. We mentioned that infection can track along the psoas fascial sheath. How does that tracking typically manifest clinically?
Okay, so the psoas fascia, being that thick, relatively strong sheath surrounding the psoas major muscle, provides a confined pathway. Infection, historically often associated with spinal tuberculosis, Pox disease, spreading from an infected lumbar vertebral body into the muscle, starts deep in the retroperitoneal space. Once the infection forms putamen abscess and gets contained within the psoas sheath, the fascia directs the flow of this pus inferiorly, following gravity and the path of least resistance along the muscle belly.
And since the psoas muscle extends all the way down, passing deep to the inguinal ligament to insert on the femur, Where does the abscess eventually present itself? Where would a clinician find it?
The pus follows that path. It tracks down along the psoas muscle, passes underneath the inguinal ligament deep to the fascia iliaca, and typically emerges as a palpable, often fluctuant, and sometimes surprisingly non-painful mass in the femoral triangle region of the upper medial thigh, just inferior to the inguinal ligament. It might also present in the groin or even track further down the thigh.
So a patient might present with a lump in their thigh, but the origin could be way up in their lumbar spine.
Exactly. This clinical presentation, a mass in the groin or upper thigh, requires careful investigation to determine if it is a true femoral hernia, an enlarged lymph node, or potentially this deep-seated psoas abscess that is tracked down all the way from the lumbar spine or iliac fossa.
And this pathology directly links back to the diagnostic physical exam technique we discussed earlier, doesn't it? The psoas sign.
Yes, absolutely.
Uh,
The presence of a psoas abscess causes significant inflammation and irritation right along the muscle fibers in the overlying fascia. Therefore, performing the psoas test, passively extending the hip to stretch the affected psoas muscle, will inevitably cause pain, often referred to the lumbar region or the groin. This links the hidden deep-seated pathology of the infection tracking within the fascia to an external elicitable physical motor sign. It's a beautifully succinct diagnostic pathway connecting anatomy, pathology, and clinical examination.
It really highlights the importance of understanding these deep anatomical relationships. Okay, finally, let's briefly touch upon the interpretation of sectional medical imaging, CT and MRI, which is obviously essential for visualizing these deep retroperitoneal structures we've been discussing. Our sources emphasize their importance starting around page 924.
Yes, CT and MRI scans are the workhorses for visualizing the retroperitoneum. They allow us to clearly delineate the great vessels, aorta, IVC, renal vessels, the vertebral column, the kidneys and ureters, the adrenal glands, the pancreas, parts of the duodenum, and the deep muscles like the psoas and quadratus lumborum, as well as the fascial layers that separate these compartments. When reviewing these cross-sectional images, our detailed anatomical knowledge isn't just useful, it's absolutely mandatory for correct interpretation. You need to know what should be there to recognize when something is wrong.
One specific anatomical consideration mentioned in the text is the oblique positioning of the kidneys. Why does this matter when looking at, say, a standard transverse axial CT slice?
Right. Because the large lumbar vertebral bodies and the psoas muscles protrude anteriorly from the posterior wall, the kidneys don't sit perfectly flat against the back like they might in a simple diagram. They're actually rotated slightly. Their medial border is more anterior than their lateral border. They lie obliquely, with their superior poles tilted slightly medially and posteriorly. This means that if you look at a transverse CT slice, the apparent posterior dimension of the kidney might look different from its true dimension, and the transverse diameter might appear foreshortened compared to its actual length. Knowing this normal oblique placement, as illustrated nicely in figures like 5.102 through 5.105 in the text, prevents a clinician from mistakenly concluding that a kidney is pathologically small, misshapen, or unusually rotated when it's actually just showing its normal anatomical orientation in that plane of section.
That's a crucial detail for interpretation. And imaging also obviously confirms the tight vascular relationships and potential pathologies we analyzed earlier.
Absolutely. Imaging is really the only definitive way to diagnose vascular anomalies like the renal vein entrapment, nutcracker syndrome we discussed, where the left renal vein is compressed between the aorta and SMA. You can often visualize the narrowed segment and the dilated portion upstream. It also visually confirms the proximity of the abdominal aorta to the lumbar vertebral column. And critically, imaging, particularly CT with contrast or ultrasound, is essential for detecting and monitoring abdominal aortic aneurysms, HERA-A. These are pathological dilations of the aorta, most commonly occurring below the level of the renal arteries. Since the aorta runs retroperitoneally, an expanding aneurysm can compress or even erode into surrounding structures, including the IVC or sometimes even the anterior aspect of the lumbar vertebral bodies. Imaging is vital for measuring the size of the aneurysm, assessing the risk of rupture, and planning for potential surgical or endovascular repair.
We've covered a remarkable amount of ground today, really wrapping up the abdomen. We started high up with the diaphragm, the double-domed chief muscle of breathing. We dissected its complex attachments and its crucial apertures, noting the functional differences in mechanism for the IVC passing through tendon, the esophagus through muscle, and the aorta passing behind altogether. We also reviewed its clinical significance in terms of paralysis causing paradoxical movement and its vulnerability to rupture, especially on the left.
We then explored the deep posterior boundary of the abdomen, focusing on the powerful iliopsoas muscle complex, the critical multi-layered thoracolumbar fascia providing stability, and the formation of the lumbar plexus within the psoas major muscle itself. We learned how deep infections like a psoas abscess can track down fascial planes and manifest externally, often diagnosable through external motor tests like the psoas sign.
And finally, we charted the course of the massive vessels of the retroperitoneum, the abdominal aorta, and the inferior vena cava. We highlighted the asymmetries, particularly the clinically important course of the left renal vein, and discussed the body's built-in redundancy for venous return provided by the ascending lumbar and azygos venous systems acting as crucial collateral pathways. So today we have truly concluded our detailed study of the abdomen chapter.
We have. And if there's one final thought to leave you with, maybe consider the sheer resilience and integrated design of the body, particularly evident in those collateral venous pathways like the azygos and ascending lumbar systems. The fact that the body anticipates potential failure of even a major vessel, like the IVC, and has these robust backup systems already in place. Well, it's a powerful reminder that the body almost always engineers a bypass. It speaks volumes about the evolutionary pressures that shaped our anatomy for survival.
That's a great concept, the body's inherent backup plans. Something important to remember as you encounter clinical challenges. Join us next time as we descend into the final region of the trunk, the pelvis and perineum. We'll begin by building the foundational bony framework of the pelvic girdle.
Thanks for listening to Bookfulness.